Thank you very much. Good morning, everyone. It's a pleasure for me to be here with you today. This is going to be the first of two onconephrology lectures that we'll give this morning. The first is going to talk about acute kidney injury in cancer patients, and the second one after lunch will talk about paraprotein-mediated kidney disease. So here are my disclosures. So I hope over the next 45 minutes to answer three important questions for you. We'll ask, how common is acute kidney injury in the cancer patient population? What does AKI mean for cancer patients? And we'll use a case-based discussion to answer the question of what are some of the cancer-specific causes of AKI. So how common is AKI in the cancer population? Well, the answer is it's pretty common. This is data from a recent Canadian population-based study that spanned 2007 to 2014. In this period of time, there were about 163,000 newly diagnosed cancer patients who started systemic therapy. Among these patients, the rates of AKI, the incidence of AKI was about 10%. And you can see that there were higher 5-year risks of AKI that are seen in certain patient populations, including those with multiple myeloma, who had almost more than a 25% risk of AKI, bladder cancer, and leukemia. And interestingly, the risk of AKI was significantly increased in the 90 days after systemic therapy was started. Now, among cancer patients, there are some populations that are at higher risk for the development of AKI, and these include critically ill patients. Up to about a third of these patients may develop AKI. Patients with hematologic malignancies like leukemia and lymphoma. Hematopoietic stem cell transplant patients, and you can see here that the rates of AKI vary from anywhere from 23 to 75%. And the reason for this is that the risk of AKI differs depending on the type of stem cell transplant these patients receive. And we'll talk a little bit more about that later. And patients who have renal cell carcinoma who are treated with a nephrectomy also are at a higher risk of AKI. So what does the diagnosis of AKI mean for these cancer patients? Well, it translates into higher rates of mortality, higher cost of hospitalization, and a higher risk of developing CKD, very much like we see in a general population that develops AKI. But interestingly, it also translates into lower rates of complete remission for their cancer. And it's thought that this might be related to the fact that renal impairment may lead to suboptimal dosing of chemotherapy in these patients. So there are many different causes of AKI in the cancer population. We can categorize these causes very similarly to how we do in the general population into pre-renal, intrinsic renal, and post-renal causes. And you can see here that many of these causes are actually similar to the causes of AKI in the general population: hypovolemia, medications, ATN. But you can also see that there are a variety of causes that are specific to the cancer population. And I hope to be able to highlight some of the more common ones in the cases that we present in the slides to come. So here's the first case. This is a 64-year-old previously healthy man who presents to the ED with worsening severe back pain radiating to the legs. He's had this back pain for about a month and a half. He's lost about 10 pounds over the last 3 months, and he denies any use of NSAIDs. On physical exam, he's hypertensive, but otherwise, there are no other abnormal findings. As you can see, his labs are not as normal. He's hyperkalemic, his bicarb is 18, his creatinine is almost 10, calcium, phosphorus, and uric acid levels are normal. He has a new reduction in his hemoglobin to 8.5. His UA shows a little bit of microscopic blood, was negative for albumin, and his sediment shows some white blood cells but no casts. He has an SPEP and immunofixation, which show the presence of a kappa light chain paraprotein. This is replicated in his 24-hour UPEP, which also shows a kappa light chain paraprotein. His serum-free light chain assay shows a markedly elevated kappa light chain concentration of over 7,000 and a markedly elevated kappa lambda ratio. He has a bone marrow biopsy, which shows a plasma cell neoplasm. So he gets admitted to the hospital. He gets aggressive IV fluids with isotonic sodium bicarbonate with no improvement in his kidney function or hyperkalemia. He started on dialysis on the second hospital day. On the same day, the decision is made to start him on plasma exchange, and he starts chemotherapy with Cybor-D, a commonly used myeloma regimen on hospital day 3 as well. He undergoes a kidney biopsy, and this is what you see. You can see that the tissue here is markedly abnormal. Here are a number of dilated and atrophic tubules, which are filled with a pink eosinophilic-like substance. And you also see on the left here, there's a substantial interstitial infiltration. Immunofluorescence shows that if you look at the tubules, they stain quite strongly for kappa light chains, particularly within the lumen, whereas staining for lambda is completely negative. And electron microscopy shows this. This is a dilated tubule And you can see the tubule is filled with an electron-dense, crystalline-like substance that has like a fractured appearance, which is a characteristic appearance of what we're looking at. So my first question for you is this. Which of the following is the most likely cause of AKI in this patient? Light chain deposition disease, light chain cast nephropathy, light chain proximal tubulopathy, or light chain amyloidosis? All in favor of A, raise your hands. B, C, and D? All right, well, it looks like the majority was correct. This is a diagnosis of light chain cast nephropathy. So let's take a few moments to talk about acute kidney injury in the myeloma population. Why is this important? Because nearly half of patients with multiple myeloma will develop some kind of renal disease sometime in the course of their disease, either acute kidney injury or CKD. AKI itself is a highly common complication of myeloma and can affect up to a quarter of patients at the time of presentation. Now, it's important to realize that patients who have myeloma who develop renal impairment have higher mortality and worse survival. However, in those patients who do develop AKI, if there's complete recovery, they tend to have a prognosis that's pretty similar to those patients who have never had kidney complications, which highlights the importance of early diagnosis and management of these patients. Now, there are a variety of different renal manifestations that can occur in patients with multiple myeloma. We can divide these by the clinical presentation, either if they present with acute or subacute kidney injury, if they present with primarily proteinuria or nephrotic syndrome, or if they present with electrolyte abnormalities. We'll talk a little bit more about these the right side in the next lecture. I want to just focus on the left panel and look at acute kidney injury. You can see here that the most common cause of AKI in myeloma patients is cast nephropathy. Other common causes include hypercalcemia, nephrotoxins, and hypovolemia. And there's some less common causes that you might see, such as plasma cell infiltration, hyperuricemia, interstitial nephritis, and these other causes as well. But these are far less common than the ones that you see above. How do we evaluate AKI in patients with myeloma? Well, this is just one way to approach the patient initially. We could try to rule out common things first, assess for nephrotoxic exposures, NSAIDs, ACE inhibitors, and so forth. Contrast, assess their volume status and acid-base status, check electrolytes, check the serum uric acid level to rule out hyperuricemia, examine the urinalysis with the sediment. If they haven't had them done already, you can check monoclonal protein studies like the SPEP, serum-free light chain assay, and a 24-hour UPEP. And it's easy enough to order a renal ultrasound to rule out obstruction because this may still be possible. Based on this initial evaluation, we can start by excluding potentially reversible causes of AKI. So if they have a history of hypovolemia, if you've identified medications that might be toxic, if they have hypercalcemia or hyperuricemia, we can try to reverse these causes first. If there's no improvement in the renal function after this, then we have to be concerned about some of these other causes like cast nephropathy. Now, the diagnosis of cast nephropathy is definitively established by a kidney biopsy. However, there are certain clinical features that may allow us to make a presumptive diagnosis of cast nephropathy without a biopsy. So if patients present with AKI and they have a bland urine sediment, they have a markedly high serum-free light chain concentration, either kappa or lambda, that's greater than 1,500 milligrams per liter, and if they have a 24-hour UPEP that shows a predominance of monoclonal proteins and not albumin, the combination of these three make a diagnosis of light chain cast nephropathy very likely, and these patients may not need a kidney biopsy. Conversely, if the patient has an abnormal urine sediment, they've got a serum-free light chain concentration that's less than 1,500, or the UPEP shows predominantly albumin as opposed to monoclonal proteins, the diagnosis of light chain cast nephropathy is less likely, and these patients may benefit from getting a kidney biopsy to obtain a definitive diagnosis. To understand the pathogenesis of cast nephropathy, we have to understand how light chains are normally processed by the kidney. So remember that both kappa and lambda light chains are freely filtered by the glomerulus. They enter into the proximal tubule where they're taken up by receptor-mediated endocytosis. So the light chains are taken up by the cubolin-megalin complex into endosomes in the proximal tubule cell, which then fuse with lysosomes, which degrade the light chains into amino acids, and these are recycled back to the body. Now, in patients who have multiple myeloma, there's an overproduction of these light chains, and the amount of light chains is so high that's filtered by the glomerulus that the amount overwhelms the proximal tubule's capacity to reabsorb these light chains. And they then flow forward into the nephron, into the distal tubule, where the light chains then interact with the normally produced TAM-Horsfall protein. And this interaction leads to precipitation of the light chains and the TAM-Horsfall protein and the formation of these casts, which obstruct the tubular lumen and prevent the flow of urine through that. This backup of pressure can cause a decrease in GFR. Sometimes the pressure buildup behind this cast is so great that the tubule actually ruptures, causing the light chains to spill out into the interstitium, and this can lead to an interstitial inflammation, which was seen in the biopsy of the patient I presented. Now, the treatment of calcium nephropathy focuses really on two main principles. The most important of these is to reduce the light chain burden, because it's these light chains that are causing toxicity to the kidney, particularly at high concentrations. The other important factor is to correct precipitating causes such as volume depletion and hypercalcemia if present. Now let's just talk a little bit about the reduction of the light chain burden. The most important thing to do for this is to administer chemotherapy as soon as possible if the patient is not already receiving chemotherapy. In this day and age, there are a number of novel anti-myeloma agents that are being used. Most regimens use a combination of drugs that include a proteasome inhibitor such as bortezomib in combination with steroids like dexamethasone, and sometimes with other drugs like lenalidomide, thalidomide, or Cytoxan. Okay. Another way to reduce light chains is extracorporeal light chain removal, and that can be done either through plasma exchange or plasmapheresis and high cutoff dialysis. And this still remains a controversial topic within nephrology. There's still no compelling evidence for or against the use of either of these modalities. And I'm going to try to show you some of the data in summary here. So what are the data for plasma exchange? Well, this is a busy slide. I'll just try to point out some of the highlights for you. There have been 3 randomized controlled trials. 2 of them are relatively small and were done over 25 years ago. The largest study was published in 2005 in the Annals of Internal Medicine, looked at about 100 patients who presented with a new diagnosis of myeloma and AKI. They were randomly assigned to either plasma exchange or no plasma exchange, and in combination with chemotherapy. The primary outcome was a composite of death, dialysis dependence, or an eGFR less than 30 at 6 months. And as you can see, there was no difference between the groups. So the authors concluded based on these data that there was actually no benefit to plasma exchange. But there's some limitations to this study that I think we should be aware of. The first is that they didn't report kidney biopsies in the study. So we don't know which patients who were enrolled actually had light chain calcium nephropathy and would have benefited from plasmapheresis, because patients who have AKI from hypercalcemia would not likely benefit from plasmapheresis. Secondly, they did not measure the serum free light chain levels throughout the study in the patients, so we have no idea if the plasma exchange actually sufficiently reduced the light chain levels. And we know that there's a correlation, in retrospective data, there's a correlation that if you're able to reduce light chain levels by 50 to 60%, the rate of renal recovery is actually pretty high. The third is that the chemotherapy agents that were used at this time are not the same as what we use now. So I would argue that the translation of this study into the current practice is not 100%. And so I'm not sure that the answer is completely clear if whether plasma exchange is useful or not. Now, high cutoff dialysis is a form of dialysis that uses a special filter that has very large pores that can efficiently remove serum-free light chains. This is not available in the US, it's available in Europe. And we have 2 randomized trials that were published in the last 2 years. One is called the MIR trial, and the other one is called the ULIGHT trial. These trials both enrolled about 100 patients with newly diagnosed myeloma, biopsy-proven calcium nephropathy, and patients who had severe enough AKI to require dialysis. Each trial randomly assigned patients to either high cutoff dialysis or conventional dialysis, although the protocols were a little bit different in both trials. The patients all received bortezomib-based chemotherapy, and the primary outcome was dialysis independence at 3 months. And both trials found that at 3 months, there was really no difference between the 2 groups. One trial found that at 6 and 12 months, as a secondary endpoint, there was a benefit seen in patients who received high cutoff dialysis versus conventional dialysis. However, this benefit was not seen in the other study, which also found a high rate of mortality in patients on high cutoff dialysis and a high rate of lung infections. So we have one trial that shows a possible long-term benefit with high cutoff, one trial that shows no benefit. I still think the jury is out, and we don't really know the answer to this question. So let's move on to a second case here. This is a 45-year-old woman with relapsed acute myeloid leukemia and a white count of 129,000 with 75% blasts. She's admitted for treatment with hydroxyurea. One day after treatment, her creatinine increases from 1.1 to 2.7, and they consult nephrology. Her exam is notable for a low-grade fever, her blood pressure is normal, she's a little tachycardic, and she appears chronically ill. Here are her labs. You can see that her bicarb is quite low at 10. Her creatinine has now risen to 3.7 at the time of our consult. She's hypocalcemic, hyperphosphatemic, and she's hyperuricemic. Her white count, which was 129,000 just a couple days ago, is now down to 34,000. Her LDH level is markedly elevated at greater than 10,000. Her UA shows a little bit of blood and protein, but is otherwise pretty unremarkable. So here's a second question for you. Which of the following statements is true about the treatment of patients with this condition? A, alkalinization of the urine reduces the risk of urate nephropathy and decreases calcium phosphate precipitation. B, allopurinol should be administered to metabolize pre-existing uric acid in the blood. C, renal replacement therapy has no role in the treatment of patients with this condition. Or D, rasburicase should not be given to patients who have G6PD deficiency. Raise your hands if you think A, B, C, and D. All right, you're all ready to take the boards. So this is a case of tumor lysis syndrome. Tumor lysis syndrome is defined as a constellation of clinical and lab findings that occur when you have the rapid lysis of cancer cells and the release of intracellular contents into the plasma. It typically results in hyperkalemia, hyperphosphatemia and hypocalcemia, hyperuricemia, and acute kidney injury. Tumor lysis syndrome most commonly occurs after the treatment of certain high-grade hematologic malignancies like lymphoma and leukemia, but can also occur with solid tumors or very, very bulky tumors that are effectively treated with cancer, and rarely can occur spontaneously in the absence of chemotherapy. Now, the diagnosis of TLS can be established using the Cairo-Bishop classification, which makes the diagnosis on the basis of both lab and clinical findings. So the lab findings of TLS include hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. And you have to have 2 of these 4 criteria in a 24-hour period, either 3 days before up until 7 days after chemo. The clinical criteria include the development of AKI, cardiac arrhythmias, or other symptoms of hypocalcemia. As I mentioned earlier, the incidence of tumor lysis is particularly high in certain kinds of cancers like high-grade AML, B-cell ALL, and Burkitt's lymphoma. It occurs less commonly in other hematologic malignancies and occurs relatively infrequently with solid tumors. The pathogenesis of tumor lysis syndrome, again, is due to the fact that these cancer cells are being destroyed, they're being lysed, and they're releasing intracellular contents, including DNA, phosphate, potassium, and cytokines. The DNA is metabolized into its nucleotides, and the purines, the adenosine and guanosine, are broken down into xanthine and uric acid. And the accumulation of the uric acid can crystallize in the kidney and cause AKI. The phosphate and the potassium can cause hyperphosphatemia and hyperkalemia. Now, if the kidney function is robust and the kidneys are able to clear these substances out effectively, the patients don't develop tumor lysis. But if there's any problem with clearing these substances or if kidney function is impaired, this can lead to their accumulation, and this is what leads to the development of the syndrome. Now, the cornerstone of management of tumor lysis is really prevention, and there are 2 main takeaway points here. You want to aggressively hydrate these patients with IV fluids. The point of this is to improve renal perfusion, increase GFR, and to try to increase the clearance of potassium, phosphate, and uric acid. You can use either IV or oral fluids. You want to target either a fluid intake of 2 to 3 liters per day before the start of chemotherapy and try to maintain a high urine output. The other component that's important is the use of hypouricemic agents to try to reduce serum uric acid levels. Now, traditionally, it was thought that urinary alkalinization would help these patients because by alkalizing the urine, you promote the conversion of uric acid into the more water-soluble urate ion. The problem here is that by raising the pH of the urine, you actually decrease the solubility of calcium phosphate, which can then precipitate in the kidney and cause injury. So urinary alkalization is no longer routinely recommended as a preventive measure for tumor lysis. Now, the most commonly used hyperuricemic agents are allopurinol and rasburicase. Again, this is the metabolic pathway for the degradation of DNA and the purines. And remember that allopurinol inhibits this enzyme xanthine oxidase, which converts xanthine to uric acid. So what allopurinol does is it prevents the new production of uric acid, and that lowers uric acid levels. However, allopurinol does nothing to lower the pre-existing high serum uric acid levels. And in addition to that, by blocking uric acid production, This can cause the accumulation of xanthine and hypoxanthine, which can also crystallize in the kidney. Rasburicase is a recombinant form of the enzyme called urate oxidase, which is an enzyme present in most mammals but not in humans. And urate oxidase converts uric acid into the more water-soluble allantoin, as well as carbon dioxide and hydrogen peroxide. A single dose of rasburicase effectively lowers serum uric acid levels within hours. So this is the drug of choice in patients who are at high risk of developing tumor lysis. Now, one thing to remember, rasburicase is very expensive, which is an important thing to think about. Secondly, the use of rasburicase is contraindicated in patients with G6PD deficiency. And the reason for this is that the production of hydrogen peroxide here can accumulate in patients with G6PD deficiency, and this can lead to the development of severe hemolysis or methemoglobinemia. In patients who have established tumor lysis syndrome, the care is primarily supportive. These patients need intensive monitoring, perhaps in an ICU setting, with close cardiac monitoring their labs. They need a dietary potassium and phosphate restriction. Most of these patients are treated with rasburicase to lower serum uric acid levels. If the patients develop severe AKI or severe metabolic disarray, they might need to start the patients on renal replacement therapy. So the correct answer to the question I asked you before is D, rasburicase should not be administered to patients with G6PD deficiency. Here's a third case. This is a 63-year-old man with metastatic pancreatic cancer who presents with hypertension, a rising creatinine, and edema. He's been treated with gemcitabine and paclitaxel for the last year and a half. He's developed worsening high blood pressure over the last month. His creatinine has gone from 1 to 1.6 over the past 3 months, and the urine protein to creatinine ratio is consistent with about 3 grams of proteinuria. His exam shows hypertension and the presence of peripheral edema. Here are his labs. You can see that his creatinine has risen now to 2.9. He's hypoalbuminemic, he's got hyperphosphatemia. His hemoglobin has dropped to 8.7 and his platelet count has dropped to 51,000 from normal. His LDH now is elevated to 254 and he's got a low haptoglobin level. His urinalysis shows some microscopic hematuria and some proteinuria. He's got a lot of red blood cells and some granular casts, and a kidney ultrasound shows no evidence of hydro. So here's his kidney biopsy. What I want to point out here is the presence of this small blood vessel, and you can see that this blood vessel is completely occluded. This is a high magnification image of a glomerulus, and you can see that the glomerular capillary loops here are quite narrow, and some of them are completely occluded. Here's one that you can see is completely occluded. This is a PAS stain of the glomerulus, and you can see that some of the glomerular capillary walls have thickening of the glomerular basement membrane with duplication of the glomerular basement membrane, otherwise known as double contours. Electron microscopy here shows a glomerular capillary loop that's got remodeling of the glomerular basement membrane. So you see duplication of the GBM, and this capillary lumen is also narrowed. And here is a glomerular capillary loop that's completely occluded. So my third question for you is this. Which of the following drugs is not associated with the development of this disorder in patients being treated for cancer? A, sunitinib, B, bevacizumab, C, gemcitabine, D, cisplatin, or E, cyclophosphamide. If you all in favor of A, raise your hand. B, C, D, and E. All right, very good. So most of you got this correct. So the correct answer here is cyclophosphamide. So this patient has a biopsy consistent with chronic thrombotic microangiopathy, and all the drugs that I listed before have been associated with TMA with the exception of cyclophosphamide. So let's talk a little bit about TMA in cancer patients. So remember that TMA is a spectrum of disorders that's characterized by occlusive microvascular thrombosis, microangiopathic hemolytic anemia, thrombocytopenia, and variable extents of end organ damage, but AKI is a common manifestation. TMA can come in primary forms such as TTP, Shiga toxin, HUS, hemolytic uremic syndrome, and complement-mediated TMA, but can also be secondary to different disorders such as cancer, infections, autoimmune disorders, drugs, transplantation, as well as pregnancy. And the point that I want you to remember is that TMA is a common complication of cancer and or its treatment. So we can think of TMA in cancer patients in 3 different main groups. The first is cancer-related TMA. And this is TMA that's thought to be directly caused by the cancer itself. The mechanisms are not entirely known. These patients typically present like they have TTP. They often have the hematologic findings as well as AKI. Many of these patients will have very advanced disease, and many of them will have metastatic disease. And there's some cancers that happen to be more commonly associated with TMA than others. And the most common one is actually gastric cancer, which accounts for about half of the cases of cancer-related TMA. Then there's chemotherapy-induced TMA, like what we saw in the patient I presented. These patients can have a variable presentation. They can either present like they have hemolytic uremic syndrome with all the hematologic findings, or they may have a renal-limited TMA, where all you see is hypertension, proteinuria, and a little bit of AKI. There's also TMA that occurs in stem cell transplant patients. This occurs in about 10% of patients who undergo an allogeneic stem cell transplant. It typically occurs anywhere from 2 weeks to several months after the transplant has been formed, and the presentation of these patients is also variable. So let's talk a little bit more about TMA associated with chemotherapy drugs. So there are a number of chemotherapy agents which have been associated with TMA. We can divide these into two main categories. Conventional chemotherapeutic agents, which include drugs like mitomycin C, gemcitabine, which was what our patient was taking. Cisplatin, remember that cisplatin typically is a tubular toxin, but it has also been associated with TMA, as well as liposomal doxorubicin. There are also these targeted agents, and most of these targeted agents that cause TMA are those that affect vascular endothelial growth factor, or VEGF. So these agents that are either antibodies against VEGF or tyrosine kinase inhibitors, which also inhibit VEGF activity, these are the ones that have been associated with TMA. And the way to remember these tyrosine kinase inhibitors, because there really are a lot of them, are that the suffix of the drug typically has a NIB or NIB at the end of it. There have been some immunotherapy drugs that are associated with TMA as well, but the most common ones of the targeted therapy group are the anti-VEGF agents. So why do we distinguish this? Because the clinical presentation of patients who develop TMA can be different depending if they get the TMA from a conventional chemotherapeutic agent or from an anti-VEGF agent. So the TMA associated with conventional chemotherapeutic agents tends to have a delayed onset. These patients are typically on these chemotherapeutic agents for several months. It's thought that the TMA is related to the dose and the cumulative accumulation of these drugs. These patients typically have permanent and irreversible symptoms. Hematologic manifestations are commonly present, and a lot of these patients will develop hypertension and AKI. Unfortunately, even after you stop the drug, there's still a high incidence of mortality and CKD in this population. By contrast, patients who develop TMA from an anti-VEGF agent can develop the TMA at any time after the treatment, even after a single dose. So it's not thought to be dose-related. When you stop the drug in these patients, frequently the proteinuria, the hypertension, and the AKI can be reversible. And the outcomes, the long-term outcomes are generally much better than in those who have the TMA from the conventional chemotherapy. So what do we do for these patients? Well, the most important thing is to stop the causative agent if we can identify one. You want to control their blood pressure, preferably with an ACE inhibitor or an ARB if they have proteinuria. There's really no evidence that the use of plasmapheresis is of any benefit to these patients. And there are a few select case reports showing that patients with refractory TMA, even after you stop the drug, might benefit from eculizumab or rituximab, but there are no large prospective studies looking at these therapies. So here's a fourth case. This is a 65-year-old woman with B-cell chronic lymphocytic leukemia who's not on chemotherapy, presents with a rise in creatinine of 1.1 to 3.4 in a period of 2 weeks, and a white blood count of 94,000. Her ultrasound shows large-sized kidneys. This is her kidney biopsy, and you can see here that there's something clearly abnormal with this biopsy. On the left here is a huge infiltration of cells that completely distorts the architecture of this kidney. On higher magnification, you can see that this is a mononuclear cellular population that's invading the kidney. And when we stain these cells for the anti-B cell marker CD20, you see that the cells are diffusely positively staining. So my fourth question for you is this: which of the following is the most likely cause of AKI in this patient? Acute interstitial nephritis, obstructive nephropathy, MPGN, tumor infiltration, or tumor lysis syndrome? All of you in favor of A, raise your hands. B, C, D, and E. All right, all of you who said D are correct. This is an example of tumor infiltration of the kidney. So this patient had CLL that had infiltrated the parenchyma of the kidney. So tumor infiltration is a common but actually under-recognized complication of patients who have hematologic malignancies. In this study of 700 patients who had malignant lymphoma, they found that about a third of patients actually had lymphomatous infiltration of their kidneys. In most cases, the involvement is bilateral. And interestingly, a very small percentage of these patients are actually diagnosed before they die. Tumor infiltration can present relatively nonspecifically with AKI, sometimes with just a little bit of proteinuria. And some patients will present with imaging findings that show enlargement of the kidneys, or sometimes they just have normal-looking kidneys, but a discrete mass within the kidney, which might look like a renal cell carcinoma. The mechanism for how this tumor infiltration causes AKI is thought to be related to the fact that as these cells really infiltrate into the renal parenchyma, into the interstitium, they increase the pressure of the interstitium, which causes obstruction of the tubules and compresses the peritubular capillaries, and this leads to a reduction in GFR. Sometimes the infiltrating cells can infiltrate the glomeruli as well and can infiltrate the capillaries, obstruct the glomerular capillaries. And sometimes these cells can release cytokines which increase the permeability of the glomerular capillary and lead to the development of proteinuria. The management of tumor infiltration is relatively straightforward. It really focuses on treatment of the primary cancer. So in the patient that I presented to you, after the biopsy was done, she was started on a combination of fludarabine and rituximab for the CLL. And as you can see, her creatinine did improve over a period of several months. Unfortunately, she was left with some chronic kidney disease, which is actually relatively common. So oftentimes, even if you treat these patients with chemo, the renal function improves but doesn't come back to baseline. I just want to mention that there are some other kidney complications that you want to be aware of in patients who have lymphoma. These include things such as obstruction, hypertension, urate nephropathy, hypercalcemia. In patients who receive radiation therapy, they can develop radiation nephritis, and paraprotein diseases, which we'll talk about in the second lecture. Here's case number 5. This is a 60-year-old man with metastatic melanoma diagnosed 2 months ago who presents to you with new onset acute kidney injury. His creatinine has increased from a baseline of 1 to 2.2. He's been treated with the checkpoint inhibitors, ipilimumab and pembrolizumab for 2 cycles, so he's gotten 2 doses. He has no history of volume depletion or NSAID use. His physical exam shows hypertension, but no edema, no rashes, no other abnormalities. Here are his labs. So his creatinine is up to 2.2. Other labs are relatively unremarkable. Here is CBC. His urine analysis shows a little bit of microscopic hematuria, but no proteinuria. His sediment shows a couple white cells, no casts, and he has relatively mild proteinuria. An ultrasound shows no hydronephrosis. So you order a kidney biopsy. So which of the following patterns of injury are you most likely to see? A, acute tubular injury. B, membranous proliferative glomerulonephritis. C, acute interstitial nephritis. D, diffuse proliferative GN. Or E, membranous nephropathy. Raise your hands if you think it's A, B, C, D, and E. Okay, so a smattering of hands. The correct answer here is C. So this is a case of acute interstitial nephritis related to checkpoint inhibitor therapy. So this patient was treated with oral prednisone, high-dose prednisone, for about 2 weeks, followed by a slow taper over a period of a month. The creatinine improved to 1.2, so pretty close to baseline over this period. And the oncologist is now thinking about re-challenging this patient with a single-agent checkpoint inhibitor therapy. So let's talk a little bit about immune checkpoint inhibitors, which have gained a lot of attention in the last few years. So immune checkpoint inhibitors are monoclonal antibodies that target inhibitor receptors that are expressed on T cells, other immune cells, and on tumor cells. We have a number of different checkpoint inhibitors which inhibit CTLA-4, which is part of a co-stimulatory pathway in immune cells, as well as programmed death receptor 1 and programmed death ligand 1. Okay? Patients who are treated with these checkpoint inhibitors frequently develop immune-related adverse events as a result of their immune system being augmented. They commonly can develop things like rash, colitis, hepatitis, hypophysitis, and nephritis. In in the published reports, the incidence of AKI in these patients is about 1 to 2% in patients who receive a single agent. So not that common, but it does happen. Or maybe up to 5% in patients who receive combined therapy with more than one checkpoint inhibitor. So what's the rationale for these checkpoint inhibitors? Well, it turns out that cancer cells can actually resist eradication from our immune system by expressing particular ligands, such as the programmed death receptor ligand 1, which when they stimulate T cells can actually downregulate the T cell response and suppress T cell activation. So where the immune checkpoint inhibitor drugs come in is they block these pathways, allowing the immune system to then recognize these tumor cells as being foreign and allowing the tumor cells to be eradicated by our immune system. Now, this is a busy slide, and I don't want you to focus on all the numbers, but I just want to share with you that these are the 4 main case series that have looked at AKI in patients who receive checkpoint inhibitors. They've all been in the last couple of years. You can see that the onset of AKI varies anywhere from about a month after receiving the drug to several months. Many patients develop pyuria, have white blood cells in the urine, but not all patients. So just because a patient doesn't have pyuria doesn't mean they don't have interstitial nephritis. When these patients are biopsied, the majority of patients have acute interstitial nephritis as the main pathology, although other pathologies, including ATN and even some GN, have been described. The treatment for this in most patients is to stop the checkpoint inhibitor and treat with oral steroids. Treatment with oral steroids leads to a pretty good recovery rate in these patients, all right? Now, the question is, if the patients improve, can we re-challenge them with the checkpoint inhibitor? And the answer is not clear. Some of these care series have shown that patients who were reinitiated on the checkpoint inhibitor did fine. They didn't develop recurrent AKI, whereas other ones showed that when they were restarted on the drug, they actually developed severe AKI again. So we don't really know the answer about this. This is just some of the guidelines that have been published in terms of how to respond to patients who are diagnosed with a checkpoint inhibitor nephritis. The general recommendation is if they have significant AKI, you want to hold the drug, treat them with oral steroids. Now, the topic of cancer, chemotherapy-related nephrotoxicity is beyond the scope of this one lecture. There's so many drugs that can cause nephrotoxicity. So I won't be able to cover all of them, but what I have included for your reference, for your studying, are a couple tables that include the most common drugs that you'll see and that associate nephrotoxicity. So I've made a table for you for common chemotherapeutic agents, for cytotoxic agents, for some of the targeted therapies, as well as some of the immunotherapy. So you can look at this on your own. So the last case I want to present is a 67-year-old man with peripheral T-cell lymphoma, previously treated with chemotherapy and radiation, who develops recurrent disease, undergoes an autologous stem cell transplant with high-dose conditioning. His post-transplant course is complicated by volume overload, jaundice, encephalopathy, low-grade fevers, and mucositis, and we're consulted on day 14 post-transplant for a rise in creatinine. Here are his medications. His exam is notable for kind of low normal blood pressure. He's gained 9 kilograms from baseline in a period of the last week and a half. He's jaundiced, his JVP is elevated, he has a distended abdomen, and he's very edematous. His labs show an elevated BUN. His creatinine's gone from 0.6 up to 1.1, so almost doubled. He's hypoalbuminemic. He's got a very, very high total bilirubin level. In most of this, it's conjugated bilirubin or direct bilirubin. Here's his CBC, he's thrombocytopenic. His UA shows a little bit of blood, no protein. Sediment is relatively unremarkable. He's got a very, very low urine sodium. And he has an ultrasound of the liver, which shows a normal-looking liver and normal flow with some ascites. So, my last question for you is this. Which of the following is the most likely cause of his acute kidney injury? Graft versus host disease, adenovirus nephritis, thrombotic microangiopathy, sinusoidal obstruction syndrome, or medication toxicity? If you raise your hand as you think it's A, B, C, D, and E. All right. So the correct answer here is D. This is sinusoidal obstruction syndrome. So the last thing I want to talk to you about is acute kidney injury in the stem cell transplant population. Why is this important? Because AKI is very common in this patient population. As I mentioned to you earlier, it can occur in anywhere from 25 to 75% of patients post-transplant. And the risk depends on the kind of stem cell transplant that they receive. So there are myeloablative stem cell transplants in which patients have their bone marrow completely eradicated before the transplant. All right, these are very aggressive. And there are non-myeloablative transplants in which they receive, their bone marrow is not completely eradicated. They receive lower doses of chemotherapy. All right. The risk of AKI is a lot higher in patients who have myeloablative transplants, perhaps not surprisingly. It's also higher in patients who have an allogeneic transplant as opposed to an autologous transplant. Now, there are a number of different causes of AKI in the stem cell transplant population. We can divide these into causes that occur early post-transplant and late post-transplant. In the early post-transplant period, you can see that a lot of causes of AKI are pretty common causes of hospitalized patients: sepsis, hypotension, hypovolemia, nephrotoxic agents. But the one entity that I want to bring your attention to is hepatic sinusoidal obstruction syndrome, which is pretty unique in the stem cell transplant population. In the late transplant period, the most common causes are thrombotic microangiopathy, which I mentioned earlier. Patients who are on calcineurin inhibitors, particularly those who've had an allogeneic transplant, they receive calcineurin inhibitors to prevent graft versus host disease. They can develop calcineurin inhibitor toxicity. And about less than 5% of patients will develop a form of nephrotic syndrome, which is typically membranous nephropathy. Now, sinusoidal obstruction syndrome, which used to be called veno-occlusive disease, presents like this. These patients present with hepatomegaly, fluid retention, weight gain, jaundice, and hyperbilirubinemia. They look like cirrhotic patients, all right? And the reason why this happens is that these conditioning regimens that the patients receive prior to transplantation damage the hepatic sinusoidal endothelial cells. And this causes thrombosis of the sinusoids, obstruction, and this leads to the development of portal hypertension. So these patients do look like they have cirrhotic livers, okay? This typically occurs, again, after patients receive high-dose conditioning regimens with high doses of chemotherapy or total body radiation therapy. And this is rather interesting because if you look at patients who don't receive the high doses of conditioning therapy, they typically don't develop this condition. So there seems to be some correlation between the aggressiveness of the conditioning regimen and the development of this condition. This is a liver biopsy showing what sinusoidal obstruction syndrome looks like. You can see here that the sinusoids are congested and obstructed. Acute kidney injury develops in about half of these patients. Clinically, these patients look like they have hepatorenal syndrome. The AKI typically presents about 1.5 to 2 weeks after the transplant. The patients have sodium retention, weight gain, and edema and ascites. If you check the urine, they almost always have a low FeNA, just like patients with hepatorenal syndrome. Urine sediment is typically bland, but if this process continues for long enough, they may develop ATN and you might see some granulocasts. Management of sinusoidal obstruction syndrome is typically supportive. You want to maintain sodium and water balance in these patients. You can give diuretics or perform paracenteses as needed to help with edema and ascites. And patients who have severe AKI or severe metabolic disarray may benefit from being started on renal replacement therapy. There is an agent called defibrotide, which is sometimes given to patients with very severe sinusoidal obstruction syndrome. This is a single-stranded oligodeoxyribonucleotide that has some antithrombotic and profibrinolytic properties. And patients who, with SOS who are treated with defibrotide have a pretty decent response rate in some observational studies. So I hope I've been able to give you a concise overview of the different types of AKI that you might see in the cancer population. The main takeaway points I want you to realize are that AKI is common in this population. Calcium nephropathy is the most common cause of acute kidney injury in patients with myeloma. Remember that tumor lysis is an oncologic emergency. The most important thing to do is to try to prevent this from happening, and this is done by aggressive IV fluid hydration and the use of hypouricemic agents. TMA can be caused by cancer itself or by agents used to treat the cancer. We've seen that anti-cancer agents or chemotherapy are common causes of nephrotoxicity. And we can see that AKI is a common complication of stem cell transplantation and can occur either early or late after transplant. So thank you for your time.